A very good afternoon. I'm here to present a poster on deceased donor renal transplantation. To begin with, the incidence of ESRD in India is about 151 per million population. However, the rate of renal transplantation is about 3.2 per million population, of which DDRT is only about 2%. We started our DDRT program in 1994 and have performed about 122 cases so far. The aim of this study is to analyze the incidence of primary non-function, delayed function, and immediate function, and also to analyze the impact of onset of graft function on the early outcome and at the end of 1 year and 3 years. It's a retrospective analysis and the data was pooled and statistically analyzed. A standard sterile 3-bag technique was used for packing and transportation. We used HTK for graft preservation, conventional immunosuppression protocol, and standard surgical techniques were followed. Mean age of donor was 31.8 years, most common cause being road traffic accident. Right graft was used predominantly, and most common cause of ESRD in the recipients was unknown, followed by glomerulonephritis. 16 patients had non-function, 63 had immediate graft function, and 43 had delayed graft function. Cold ischemia time, less than a cutoff of 6 hours, had relatively lower incidence of DGF in our study. Talking about the impact of vascular anatomy, 88 kidneys had normal anatomy and 33 had anomalous arteries, of which 10 underwent double artery anastomosis and 5 had safe ligation of the upper pole artery. Of these, 5 cases had delayed graft function and 9 had immediate graft function. There was statistically no significant difference between the onset of acute rejection or new onset diabetes after transplantation and mortality at the end of 1 year. But there was statistically significant difference in the mortality at the end of 3 years between these two groups, most common cause being sepsis. The use of grafts with multiple renal arteries has been associated with increased incidence of vascular as well as urologic complications in our study. Poor socioeconomic status, personal hygiene, and improper follow-up were also barriers to the outcome. And we are making all the necessary efforts to educate them and following up with telephonic conversation. This DDRT model of Tamil Nadu has evinced interest among other states of India. Thank you.